I love mine. So welcome everybody. It's great to see you all. And I'd like to introduce Professor Camara Jones, who's joining us tonight, which is great. This is the second time we've been in Lambeth. I think in the last year, is that the time? Yeah, brilliant. So Camara is a distinguished public health specialist in health and equity. So yeah, really great to have you here. You've got lots of experience in health inequalities, health disparities, and I'm going to talk us through that today. Particularly, I guess, in terms of racism and other protected characteristics. And I think that really kind of lines up with an event we had on Monday, which is an inspiring event where Kevin Benton talked a lot about racism being a social determinant of health. And I know we've talked about that. I'm going to talk a bit more about that later. Your leadership positions have included the president of the American Public Health Association, and you've been recognised nationally and internationally for your groundbreaking work. So in terms of equity, your expertise, understanding of social determinants is clearly really renowned, and so we're very lucky to have you here. And I guess that for me is really important in terms of your commitment also to ensuring that you're engaging with communities and really understanding the kind of perspective from communities and how they absolutely play a pivotal role in the work you're doing. So I think I'm probably not going to say much more because I'm sure you can say, you can speak and tell us more about you. But welcome, it's great to have you here. Thank you.
Thank you. And I'm actually really delighted to be here. My superpower, if you will, is in the use of allegory to talk about these hard issues like inequalities and anti-racism and the like. So I've entitled my remarks today, Anti-Racism in Public Health, a cliff analogy, a restaurant saga, a gardener's tale, and other powerful tools. So those things, by the end of our conversation, you will know exactly what they are. But those are allegories to help us understand different dimensions, if you will, levels of health intervention. One, to understand that racism exists and how do we communicate that to other people. And then to understand that racism operates on at least 3 levels of racism. So here we go. We're going to see. So I also want to say, this is the first time I've included such a slide, but this is just my good practice now. It's a copyright slide with a suggested citation because people have started just taking my stuff. So I want you to use my things, but with permission, or with appropriate citation with all of that. So I'm going to start out with what I describe as my cliff analogy to understand different levels of health intervention. And this is an image that I use either with the general audience or especially with health, public health, or they could be medical, specifically or whatever, to help them understand why should we be thinking about racism, right? Like, what does that have to do with our practice? So here we go. What? Oh. Somebody has just fallen off of the cliff of good health. And if that were you or somebody in your family, you would be delighted to find an ambulance at the bottom of the cliff to speed you on to care. But if we cared about other people who might come along that cliff face, that is, if we cared about public health, community health, population health, we might well ask ourselves, what could we put in place as a health intervention besides just stationing lots of ambulances at the bottom of the cliff? So somebody in this room is going to say, I know, let's put a net halfway down. That way, even if people fall, they won't get crunched up at the bottom, right? And that's a good idea, right, to have a net there. But the more you think about it, nets do have holes. So some people might fall through the cracks. But we could even make that a trampoline. I didn't draw a trampoline, but we could make that a trampoline halfway down that cliff. Right? But even if we had a trampoline, no holes in a trampoline, we might still find ourselves with lots of people just bouncing up and down at half functionality, not able to get back to the top of the cliff. So what else could we put in place as a health intervention? Well, clearly, we could put a fence at the edge of the cliff to keep people from falling in the first place. But even that fence would have to be a very, very strong fence if there's a lot of population pressure against it. So what else could we do as a health intervention? Well, we could move the population away from the edge of the cliff. So let me label the interventions that I have depicted so far. Where the ambulance at the bottom of the cliff represents medical care, as well as tertiary prevention. So here we are, public health. We know about 3 levels of prevention: primary, secondary, tertiary. Tertiary prevention is preventing the complications from disease that's already manifest. So preventing amputations from diabetes, that kind of thing. The net or trampoline halfway down, these are our safety net programs, which can be, often in social services and the like, as well as secondary prevention, which is early detection, screening, which could be in clinical settings or community settings. The fence represents primary prevention, keeping bad things from happening in the first place at the individual level, person by person. The fence is keeping people. And moving the population away from the edge of the cliff is about addressing the social determinants of those determinants of health and illness that are outside of the individual. They're beyond our individual genes, they're beyond our individual behaviors. They are, in fact, come on in and sit down. Come on in. These social determinants of health are actually the conditions of our lives, right? So we have the individual conditions of our lives, like individual education, occupation, income, and wealth. So clearly, moving the population away from the edge of the cliff includes anti-poverty, but also neighborhood conditions, whether there's fresh fruits and vegetables available. This is, I think, more of a problem in the US than I've observed here in London, but I don't know how rural, UK is or not. But, just neighborhood resources and the like. So addressing adverse neighborhood conditions is another way of moving people away from the edge of the cliff. So, this is a nice little diagram. You could go into a community setting and you could say, okay, we have found that diabetes is an issue in this community, and we have some resources. How should we spend those resources? How much on ambulances versus meds versus fences versus moving the population, right? And you can have a very fruitful conversation with Parliament. You can have lots of fruitful conversations about this. And just to give you an example of, with regard to infant mortality, for example, the ambulance might be our neonatal intensive care units. The net or trampoline might be prenatal care, which is, after all, preventive, examinations of women. The fence might be programs that invest, either group prenatal sessions or investing in fatherhood, things, that kind of thing. Moving the population away from the edge of the cliff would be a living wage or excellent educational opportunities, so that some girls didn't feel that their main option was to have babies too soon. So you could understand HIV, you could understand non-health things along this cliff, right? Educational outcomes, where you have the acute intervention versus the investment, I would say, or housing. So this cliff works for a lot of things, but cute as it is, it has a huge fatal flaw. And the huge fatal flaw is that it does not yet help us understand how health disparities. So I want you to keep this clip in the back of your mind. And we're going to just briefly talk about how health disparities arise on 3 levels. And then we'll come back to the clip. Now, these 3 levels of how health disparities arise are clearly based in my US experience. And I was here in the UK for a year as a Lieberhume visiting professor at King's College London from July 2022 to July 2023. So I have a year's worth of a little bit of a UK experience. So I'm going to talk about it from both the US and the UK perspective. But especially in the US, back in 2000 to 2003, we had the publication of unequal treatment, of report from the Institute of Medicine documenting differences in the quality of care received within the healthcare system by ethnicity. And that unequal treatment report sent shockwaves. I don't know if you guys have had a similar kind of review of the literature type of thing, because this is now 21 years ago, 21 years ago that this came out. But this was, even once people were in healthcare, there might be differences in how vigorously their chest pain might be investigated or treated, depending on their race or ethnicity, or differences in how much pain medication they might get if they presented in an emergency department. So what do you guys call it? A&E, right, accident and emergency, with a long bone fracture, depending on their race or their ethnicity. But even the people who wrote that report said, we know that's not the end all and be all of how health disparities arise. We are dismayed, but need to know that there are differences, that people are being treated differently within the healthcare system. But some people don't even have access in the US to the healthcare system at all. And I've observed that the access to healthcare, even though you have a national health service, is differential in terms of timeliness and stuff, even here in the UK. So that's a second level at which health disparities arise, where differences in access to healthcare, including both preventive and curative healthcare. But then I'm hoping that everybody in this room recognizes that health is not created within the health system or the health service or even, health and social care, and that there are differences in the conditions of our lives, differences in our life opportunities, exposures, and stresses, which are making some people sicker and some communities sicker than others in the first place. So when we think about these three levels at which health disparities arise, differences in quality of care, differences in access to care, differences in underlying exposures and opportunities, we could depict that pictorially as a pyramid, for example, or better yet, as an iceberg, where the huge hidden base are the differences in the conditions of our lives. And then very often, the same people who have been made sicker have less access. That's clearly true in the US, and to some extent, I would say here in the UK, less access to the healthcare system. And then sometimes even the lucky ones who get into the system are sometimes further injured because of differences in the quality of care. So now, remembering those three levels at which health disparities arise, we're going to go back to that cute little cliff. But now we're going to recognize that we're not really dealing with a flat two-dimensional cliff, but actually we are dealing with a three-dimensional cliff. And at some parts of the cliff, there might be an ambulance there, but maybe that ambulance has a flat tire, so it's slow or goes off in the wrong direction. Or maybe there's no ambulance there at all, and maybe there's no net nor fence. And usually at those parts of the cliff, the population is being pushed closer to the edge. So now that we recognize that we're really dealing with a three-dimensional cliff, let me label how health disparities arise on this three-dimensional cliff, where the differences in quality of care are represented when there might be an ambulance there, but that ambulance is slow, it goes off in the wrong direction. Differences in access to care, no ambulance, no net, no fence, and differences in underlying exposures and opportunities are represented by the closer proximity of that greeny population to the edge. So now that we recognize we're dealing with a three-dimensional cliff, there are a lot of questions that arise. The first, of course, being, how did the cliff become three-dimensional in the first place? And that is usually because of historical injustices that are perpetuated by present-day contemporary structural factors. But given that the cliff is three-dimensional, we also need to ask, well, why are there differences in how resources are distributed along that cliff face? And why are there differences in who's found at different parts of the cliff? Why are the oranges back here in a way and the greenies being pushed closer to the edge? And when we start asking and addressing these kinds of questions, we are now doing something that differs from addressing the social determinants of health, which I described as moving the population away from the edge of the cliff, addressing poverty, adverse neighborhood conditions, and the like. We are now doing what I describe as addressing the social determinants of equity or inequity, which are systems of power that can differentially distribute resources and population. And include racism, sexism, heterosexism, all of these systems of structured inequities. So there I actually would say, I showed you 5 levels of health intervention: ambulance, net, fence, moving the population, addressing the three-dimensionality of the cliff. But these are actually along 3 dimensions of health intervention, where, 1 dimension is a line, 2 dimensions is a flat plane, 3 dimensions is space. Well, along that line at the edge of the cliff is where we can array all of our curative and preventive health services. In fact, in the US, and I think to some extent here, if I say the word health, people immediately go to health services, health care, right? I mean, that's so much. So when people think of health, they're thinking about along the edge of the cliff, curative and preventive, but at the individual level along the edge of the cliff. And we in the US, oh, would we love to have a national health service? I know yours has been starved for 14 years now, right? But we don't even have that. We don't have a healthcare system. We have scattered healthcare systems with lots of holes and gaps in between. But even when we get universal access to high quality healthcare, which, in the next century, hopefully we do, even when we get that, when I'm in the US, I said, that's great. That's how a civilized society values all of its people equally. But even when we get there, that in and of itself would not result in the large and sustained improvements of health outcomes or the elimination of health disparities, right? Because you can overwhelm any system if you're pushed up against the edge. So clearly we must go into that second dimension, which I can display along a flat plane. We must address the social determinants of health. So housing, transportation, food systems, educational systems, and the like. We must move the population away from the edge of the cliff, right? In order to have large and sustained improvements in health outcomes. But here's the trick. If we're moving the population away from the edge of the cliff without recognizing that we're really dealing with a three-dimensional cliff, we are at risk of moving some of the population, but not all of the population, and actually making health disparities worse. So we must go beyond that to acknowledge and address the three-dimensionality of the cliff. We must be about addressing these social determinants of equity or inequity, including racism, sexism, heterosexism, and the like, if we want to achieve social justice and eliminate health disparities. So here I'm making, and Kevin Fenton and I are great friends. We're together on the O'Neill-Lancet Commission on Racism, Structural Discrimination, and Global Health. And I know it's easier here in the UK to talk about social determinants of health than it is to talk about racism and anti-racism. So I experienced that for a year because I came here to talk about racism and anti-racism. Many people eagerly, seeking me out, but coming into a setting where the Sewell report, the Commission on Race and Ethnic Disparities, I just couldn't understand that, where they documented all of these disparities by race and educational outcomes, health outcomes, and police encounters and all, and then made a statement that there was no racism. Right. So this country, like my country, the US, has a lot of racism denial. Right. It's so prevalent and so seductive, right? So I recognize that. And so I recognize why Dr. Fenton, Professor Fenton needs to do that. But the distinction between social determinants of health, which are the conditions, I would say, of our lives, and the social determinants of equity, which are, it doesn't just so happen that this neighborhood has this stuff and that neighborhood doesn't. It doesn't just so happen, and it's about who's at the decision-making table and who's not, in terms of, and who's prioritizing what, and what kind of communication are you having. It's really about, I'm going to talk about that a lot more, but it's that we have to attend to. That is the difference. So addressing social determinants of health in the US context might be having a bike trail, or having a garden project, or farmer's market, or something like that. Addressing the social determinants of equity would be who's at the table deciding where the bike trails are going, or even what communities want, and do they want a bike trail or not? So who's at the table? So that's the difference, and that's a very important difference to attend to, especially for people like you guys who are in decision-making and funding roles. So I'll just say one little thing here, so that I know that you must have an excellent communication with community folks, but that's the most important thing. I worked at the US Centers for Disease Control and Prevention for 14 and a half years. And it is hard to sustain from a health agency. It's hard to keep those inside-outside connections alive. They tend to depend on individuals, and then somebody moves or somebody changes jobs or whatever. And it is the role of these institutions to make their institutional walls more porous, so that it doesn't depend on individual relationships, but there's a structural way to invite that back and forth, that sharing of genius and input and the like. But anyway, I so digress. But I'm going to just finish up with 3 questions that in the US context I was asked a lot, and might help you with that still relate to this clip. And then, because we're just the perfect size, for me not to talk for an hour and then you have 30 minutes of Q&A, but for us to talk to each other. When I finish with those slides, then let's talk about this story before I launch into the other two. So the first question, now this is really pertinent in the US context. If Dr. Jones, what you say is, a good depiction of how we could spend our health resources, and if an ounce of prevention is worth a pound of cure, then why are we spending so much money on ambulances at the bottom of the cliff? And there are so many answers for that. I actually need to catalog now. I know I've had at least 6 answers, but now I'm just going to share with you 2, because these are the ones that the first most cynical one and then the deepest one. The most cynical one is that there's a lot of money being made, especially in the US, by ambulances at the bottom of the cliff. So, healthcare systems, healthcare providers, drug companies, medical device companies, a lot of that going on. But the deepest answer is that in the US context, we are so narrowly focused on the individual that we don't even recognize that there's a health problem until somebody has fallen off the cliff and either gets caught in our nets or we scrape them off the bottom and speed them on to care. This narrow focus of the individual on the individual is actually one of 7 what I call cultural or societal barriers to achieving health equity. And although I don't plan to include them in my prepared slides, ask me about the others if I don't come to all of them right there. But that's the first, that narrow focus on the individual. We in the US do not even use measures of aggregate measures like income inequality or, social cohesion or anything. We're not trying to measure anything up here. We're just measuring the people one by one and we don't even know how to measure how many people get at the fence. That's, of course, the universal problem with prevention. How do you demonstrate how many people you prevented from getting measles? How do you demonstrate how many people you prevented from getting COVID? How do you demonstrate how many amputations you prevented? That's a hard question for all of us anyway. But we could spend a lot of time trying to measure those things. But instead we just count. Okay, so that's the first question. The second question, here I have, why are the greenies launching themselves over the edge of the cliff? I used to hear that in the US as, why are those people eating so much fried chicken? Or why aren't those people reading to their children? Or why are they doing this? Or why aren't they doing that? Which also relates to the narrow focus on the individual, because when you're narrowly focused on the individual, it makes systems and structures invisible or seemingly irrelevant. So we don't even see the systems and structures that are pushing the greenies to the edge and keeping them there. But it also relates to the second of my 7 barriers to achieving health equity, which is that we as a nation in the US and here are ahistorical. We act as if the present were disconnected from the past and as if the current distribution of advantage and disadvantage were just a happenstance. And so, yeah, I'll just leave it there because I know I could talk 10 more minutes just on that slide and I need to keep it moving. Here's the third question, which most people will not say out loud, but here it is. This situation looks fine to me. What's the problem with a 3-dimensional cliff? Now, although most people would find that embarrassing to say, many of us act that out in our lives when we might leave. Again, I'm going to go to an image from the US, but we might leave our beautiful homes in a beautiful, beautiful gardens, a beautiful neighborhood and maybe gated community and all like that. And we might drive through a disinvested, poisoned, poor community. And then we arrive at our beautiful workplace, guard at the front and all of that, and not feel a strong sense of urgency to do something about that disinvested, poisoned community that we just drove through. And that reflects a third of these 7 barriers to achieving health equity, which is our endorsement of the myth of meritocracy. The story that goes something like this: if you work hard, you will make it. Now, I don't know if you guys have that story. We have it in many ways. Horatio Alger's story, pull yourself up by your bootstraps. So we have so many versions of this. And I would be interested to learn, if there are specific children's books that you guys have that promulgate this myth of meritocracy. But it goes like that: if you work hard, you will make it. Now, I give you that most people who have made it have worked hard. I didn't say everybody who's made it has worked hard, because you guys have the monarchy, we've got Trump, you know. But most people who have made it have worked hard, but there are many, many, many other people working just as hard or harder who will never make it because of an uneven playing field, which has been structured and is being perpetuated by racism, sexism, heterosexism, all of these systems of structured inequity, which I had described as in, social determinants of equity. That language is from not 20 years ago when I first published it, but I keep it there. But because it's all these same things. And so when we deny the existence or pertinence of racism, sexism, heterosexism, when we deny the existence of these systems of structured inequity, then we blame people who haven't made it as being lazy or stupid. So we don't even recognize that these greenies here may have built all the ambulances, nets, and fences. Then they got moved to another part. They built some over there too, and then those got burned up or taken away, in the US context, with all of the communities of color in the early 1900s with massacres and the like. And people may not even recognize that it's more slippery at the edge here, and every step that they try to take back might be harder than somewhere else. And in fact, the oranges probably don't even know any of that, because they are never looking over at people closer to the edge of the cliff, because everybody compares himself to people who have more. Right? So there may not even be an acknowledgement or an interest or a curiosity about what's happening. Anyway, again, I'm going too deep. I digress. So why don't we take 3 comments, questions, observations, challenges, or whatever, and anybody want to say anything right now?
No, not me. I just okay, sorry.
No, you're not forgetting something. So I love your cliff analogy. I think it's brilliant. I think it really tells a story about, in a different way than I've seen actually. I was wondering, so one of your questions was around where the spend is, which is at the bottom of the cliff. And I was wondering, a lot of people are talking about the commercial determinants of health at the moment. Where do you see that in the cliff?
Well, I guess right there, because I haven't heard about the commercial determinants of health. That hasn't gotten over to our US, but I guess they're talking about capitalism, right? Which as a system is one of the structural determinants of health. So that's something that helped to create and perpetuate the 3-dimensionality of the cliff. And so it manifests everywhere, because it manifests in the distribution of resources. It manifests in combination with racism in the differential distribution of people. So the distance from the edge of the cliff has to do with social class. But capitalism as a system of exploitation of, some people own the factories and other people work there, is also intrinsically doing that. So there, but the fact that there are racial differences do not just so happen. It is important in this country and in the US to recognize that when we see differences in social class by race, that's not just a happenstance. That's because of it's because of initial historical injustice is perpetuated by structural differences. In the US and in the UK, I would say, both racism and capitalism or colonialism, that means settler colonialism, are foundational in our nation's history. In both countries, many people are in staunch denial of the existence of racism and its pertinence in past, or certainly not today. So I am going to show you when I define racism in a minute, and then show you how that definition of racism can be generalized to be a definition of any system of structured inequity, including capitalism. Then you might ask me, well, so Camara, why are you so head up on talking about race as an axis of inequity and racism as a system of structured inequity when you recognize many of these other axes happening? And it is precisely because racism is foundational in our nation's history, and yet many people are in denial of its existence. At least in the US, and I would say here, people recognize that capitalism exists. They celebrate it in my country. But there's no denial. So that, I'm sort of preempting what I'm going to say, but I actually think that all of us need to be actively anti-racism, even as we engage in as many of the other struggles as we can. And to the extent that we're able to dismantle the mechanisms of racism, the other struggles will benefit as well. But anyway, I don't know if I answered your question. So clearly, yeah, there's some stuff going on, but capitalism itself, I hadn't heard about the commercial determinism of is manifest throughout. It is also a system of structured democracy. Other questions or comments? No struggle. Struggle to say something. Yes, please.
So I need time. I think that because there was something you said about not that they don't connect history to current day, and I'm British. I'm part of the Windrush generation. My parents came to this country, and what I'm noticing is that my generation are dying at a faster rate than our white counterparts. So I went to school in North London. There's been, including my own sister, died 2 years ago, there's been a high percentage, and it's usually breast cancer, prostate cancer, and sort of along that ilk. But years ago, my doctor, who's married to a Black woman, said that there's a piece of research that shows that when our parents came to this country, there was no health plan in place thinking about what they may need. And they didn't expect our parents to have children. So they didn't realize that they should be giving the children of those people vitamin D from the day they were born to when they were 18. And he was saying that that's why there's this disproportionate number of my generation who are now experiencing these, I think it was he named 4 illnesses that are, and I'm noticing that he told me that probably 15 years ago. And now I'm like, oh my gosh, he's probably got a point. So when you said there's a disconnect, when COVID happened, there was this whole thing that in the Black community was seen as our lifestyle, why we were more susceptible to COVID. But then I had to think back to what he said about this thing about vitamin D. And the main thing they were saying to people throughout COVID was take more vitamin D. And I was thinking, well, actually, we probably so lacking because we didn't get it from childhood.
That's interesting. So I don't know the vitamin D hypothesis, but I think it's important for us to ask these questions. We need to ask why. We need to go beyond just documenting differences in health outcomes and try to understand why. But when we ask why, we need to look at vitamin D. We need to look at the policies that were about that. We need to look at current living conditions. We need to look at current policies that are having higher exposures or less access to all of that. So what I take from your thing is I can't comment on the vitamin D. I would actually think that, people are looking at vitamin D a lot, but then I've heard more recently that people think, oh, it's hyped up. So I'm not in the vitamin D. I don't know that story. But the important part of it is we can't just document differences by populations. We always need to be curious why. And we can never use race or ethnicity as an explanation because race is not in our genes. There's no biological basis for race. It's a social classification in a race-conscious society. And what we often get tripped up in is people, especially in the US, this idea of racial subspeciation has been so, it was the justification for the enslavement of people of African descent in the life. And it's been so used and it's so ingrained and it's dangerous for all of us to understand. May I just, before you go, I'll just give you an example. Now, I may not remember exactly, it's been 20 years since I thought of this example, but in the US, people might say, oh, well, Black people have more high blood pressure because, they were the survivors of the Middle Passage had to have salt saving and stuff like that. So if you think that the kidneys are saving more salt because they're the survivors of people from the Middle Passage, then all you can do, and you can't change their kidneys, then all you can do is screen Black populations for hypertension and then treat them. But if we understood why Black people were at higher risk of hypertension, then we could prevent the hypertension before it started. So in Papua New Guinea, there was a severe neurological disease. I can't call the name of it right now, but it was observed only among the native people, not among the missionaries from Europe and all who were there. And so there was this strong sense that it was, genetic or biological, something about those people, until it became clear that it was because of funeral practices. It was a neurological disease where the prion, so the subviral particle, was in the brain, but to honor people who died, then people would eat part of the brain, and that's how it was transmitted. So when that was finally understood, then that could be prevented, that those people could be helped. But not only that could that help those people, that prion knowledge then helped when there was mad cow disease here in the UK and Europe. So it's not, so we need to ask why and do the science and not attribute things to race. Right? It helps not only the people who are affected by the disease, good to wonder for them, but it helps all of us. It advances the system. I think that yes.
Just really quickly, so I love your diagram too, I think it's great.
Thank you.
But also just, I guess there's something for me about, I think going on from what you were saying, about how, and it'd be good to get your thoughts around how we move away from blaming populations for their own health. Because I think that's a real issue around how we tackle these issues. So when we talk about breast cancer, we always talk about, well, actually Black women just get screened more often, or it always goes back down to, or the responsibility gets left with the community or the population, rather than looking at what is the system doing differently to ensure that it's accessible for those communities.
That's
So
right.
it's just really good to hear your thoughts.
Yes.
I want to add something to that question, because one of the things that I think I'm really aware of is how we use AI more and more in medicine, how we generate algorithms to test people, and that's all around the ambulance space. And what you find is, because of the differential access to healthcare, we're already building in assumptions to access, to Juliet's point. That means that people almost will be missed out from some of that as a result of that. So it goes beyond that sort of individual community thing, but we're almost designing it in now as our baseline.
So we're using the situation as the normal, right, in the AI. So it's that the narrow focus on the individual is dangerous because it makes systems and structures invisible or seemingly irrelevant. So to have a structural lens is a very important thing. That's why when people talk about structural racism, so the next, by the end of the Gardener's Tale, I will give you a tool to help people understand how to talk about structural racism. But it's that that all of our kind of Western European and US and all of that stuff that was spread with the colonial enterprise, right, has this narrow focus on the individual, which blames, says that the solution has to be at the individual level, all of that, right? And we need to be understanding that we do not have, I don't know, I might offend some people here. So we have constrained free will. We have free will constrained by the conditions of our lives. And unless you're at the decision-making table, determining the conditions of your life and everybody else's lives, then we don't have free will. So we need to back it up to what are the decisions that we're making and what are the value systems underlying those decisions. And I can, who's at the table, who's not, I'm going to talk a lot about it. So I am going to carry on. So that whole thing that I just spent time on, the clip analogy, is how I, with the general audience, say, and I said racism 3 or 4 times, nobody fell off their chair, let's go. Or for a health audience, how I said, look, this is something we need to take care of. Like, we need to address, even if your main job is to be the best ambulance driver you can be. If you're a medical student or whatever, and you're trying to be the best ambulance driver, and we need great ambulance drivers, we need strong nets or ambulances, we need, nets or trampolines, we need strong fences, we need powerful stuff pulling people away. We need to acknowledge and address the three-dimensionality of the cliff. We need all that. But even if your job is to be the best ambulance driver you can be, you need to wonder, is there a net above me? How strong is that net? Is there a fence at the end of the cliff? How strong is the fence? How close are the people to the edge? At what part of the cliff am I operating? Do I even do things the same way when I'm operating at different parts of the cliff? So for each of us, if we're trying to be a net, whatever we're trying to do, we need to understand that the rest of this pulling together is necessary for a strong system. That's for your day job. But as a global citizen, as somebody who cares about the whole, I would say our first job is to back up from the three-dimensional cliff. We need to be addressing things there. So for your day job, you just understand your interrelationships and you try to help out as you can and you build bridges and stuff. But as individuals, global citizens, we need to be first concerned about the three-dimensional cliff and the differential distribution of resources. Okay, so now I was president of the American Public Health Association in 2016. I used that platform to launch a national campaign against racism with 3 tasks. The first task, to name racism, to say the whole word, because we must name a problem in order to get started on the solution. But naming racism, as necessary as it is necessary but insufficient. We need to go beyond naming racism and move to action. Or we can get, there's a analysis paralysis. Okay, show me more studies that racism is impacting this, that, and the other. Well, what about over here? What about over there? And what we need to do is move to action. So the second of the 3 tasks is to help us target our action for most impact. And that is by asking the question, how is racism operating here? Where the here could be in my child's daycare or, preschool. Or it could be in my job or in my neighborhood or whatever. But you ask, how is racism operating here, to identify levers for intervention, targets for action, which would be good early places for you to put your energy. And then once you've done that landscaping, then you need to organize and strategize to act. Now, clearly, each of us has individual agency and power. And so I'm not saying that we can't do things on our own. We can put things on agendas at meetings. We could hire a student or hire a faculty person. We could go out and organize with, community folks or whatever. Well, I already said the organizing, but so as an individual, we have power, but collective action is real power. Collective action informs us, inspires us, propels us, protects us, and so much more. So even for that first step, so I said 3 steps. Name racism, ask how is racism operating here, organize and strategize to act. And if I don't say it again, I just need to say that those steps are sequential, but when you get to the end, you're not done. They're also iterative, and the whole effort may well span generations. Hopefully I'll have more time for more detail on that. But even for the first part, naming racism, where I've already told you, it's hard in the US, it's hard here, right? There are 4 key messages for naming racism. The first is that racism exists. Right, and there's so many people with racism denial. So that's the first key message. Racism exists. The second is that racism is a system. So we're not talking about individual character flaws, personal moral failings, none of that. I mean, those exist too. Racism in its essence is a system. The third is that racism saps the strength of the whole society. It's just not, oh, poor those people. Right? And the fourth key message is that, yes, we can act, dismantle racism. So the second of the 3 stories I'm going to share with you is my dual reality Restaurant Saga, which is a way. Did you guys know it already? No, okay, something, okay.
Looking forward to it.
That's great. So this is a story I tell either to people who don't know that racism exists, or for people who know that racism exists, to have a little something in your pocket that you can talk to your friends or neighbors or anybody on the bus in 5 minutes to help them with an image that helps them understand this. So this story, like most of my allegories, the other was like more theoretical, but I also have a lot of allegories based on my own real life experience. This one was based on when I was a first-year medical student. So here I am, first-year medical student. You know, I was diligent, right? I was studious. So on a given Saturday, like on most, I woke up early and I hit the books immediately. I'm just nosing and reading and, studying. And it got to be about mid-afternoon and some friends of mine came over. Now, did they distract me from my studies? Oh, no, well, they were medical students too. So what did we do? We all got together studying long and hard. Now it was getting later and later, and we were getting hungrier and hungrier. And I had no food in the apartment, which was so typical of me that my friends actually understood. They were like, okay, Camara, we got that. You don't have any food in here, but we're hungry. Let's go out and find something to eat. So we go into town, we find a restaurant, we walk in, we sit down, menus are presented, we order our food, food is served. Here we are eating. Now, little sidebar. I am old enough that people in my generation, if I told you I was going to tell you a story about a restaurant and racism exists, would have thought that the story was I wasn't served. But okay, here, we're served, so now let's pick it back up. So now you're wondering, well, where's this story going, Dr. Jones? As I sat there eating with my friends, I looked across the room and I noticed a sign that was a startling revelation to me about racism. So now I hope I've intrigued you. And you're wondering, okay, Dr. Jones, what did the sign say? Okay, here it is. What did the sign say? The sign said open. Ooh, so now I've lost many of you. How is a sign that says open a startling revelation about racism? So let me recap. Here I am, sitting with my friends eating. I look across the room, I see a sign that says open. Thinking no more about it, I assume other hungry people can walk in, sit down, order food. But because I knew something about the two-sided nature of those signs, I recognized that now indeed the restaurant was closed due to the hour, but firmly closed, and that other hungry people just a few feet away from me, but on the other side of that sign, would not be able to come in, sit down, order their food and eat. And that's when I recognized that racism structures open closed signs in our society, that racism structures, if you will, a dual reality. And for those sitting inside the restaurant at the table of opportunity eating, they look up, they see a sign that says open, they don't even recognize that there's a two-sided sign going on because it is difficult for any of us to recognize a system of inequity that privileges us. It is difficult for men to recognize male privilege and sexism. It is difficult for white Americans, white Brits, to recognize white privilege and racism. It is difficult for all Americans to recognize our American privilege in the global context. Oh, we were living at large with the COVID vaccine at the beginning. We sequestered so much of the global supply of COVID vaccine in our country. But those people on the outside are very well aware that there's a two-sided sign going on because the sign proclaims close to them. They can look through the window and see people inside eating. So back inside the restaurant, to those who ask, is there really a two-sided sign? Does racism really exist? I say, I know it's hard to know when you only see open. In fact, that's part of your privilege, not to have to know. But once you do know, you can choose to act. So it's not a scary thing to name racism, it's actually an empowering thing to name racism. It doesn't even compel you to act, but it does equip you to act so that if you care about those on the other side of the sign, which is ahead, but if you do what, why, you could even talk to the restaurant owner who is, after all, inside with you. And you could say, restaurant owner, there are hungry people outside. Why don't you open the door, let them come in? You'll make more money. And oh, the conversations we could have. Or maybe you'll pass some food through the window. Maybe you'll try to tear down the sign or break through the door. But at least what you won't be doing is sitting back saying, wonder why those people don't just come on in and sit down and eat. Because you'll understand something about the two-sided nature of that sign that proclaims open to you. So when I have 5 minutes or so to share a story that helps people understand viscerally how racism could exist for their whole life, they've been, living that this is a land of equal opportunity in the US. I don't know how you guys say it here, but this is the story, It's not similar. So this is the story I tell. And in fact, I have been able, so on 2 separate real occasions, when we had lots of time, I sparked conversations that lasted 3 hours, 2 times, when I asked the simple question, how could people who were born inside the restaurant know something about the two-sided nature of that sign? And these conversations were 3 hours long because there are many ways to know. I am grateful that people who were born inside the restaurant and who just 4 years ago might have been sitting aside eating and then saying, what are those people outside saying? Black Lives Matter. Don't they know all lives matter? Are now actually proclaiming, yes, Black Lives Matter, although people, right? People who were born inside the restaurant now able to say the word racism, putting together the phrases structural racism, systemic racism. That's very heartening. But here's my warning. If all that we do is say racism, put it on our websites, have some program, but then not really, then 6 months from today, we might forget why we said that word. Because racism denial is so staunchly held by so many in both of our nations, and it's so seductive, we might fall into what I describe as the sleepiness, the somnolence of racism denial. So we have to go beyond naming racism to action. Maybe we need to tear down the sign that, of course, racism is not just a sign, it's a sign, it's a door, it's a lock. There's a whole system going on. We need to dismantle the lock, takes the door off the hinges. Once we start acting, we will not forget why we are acting. So that is my story for now. Before I open it up, I'll come to another natural point, okay? And I'm actually going to come back to that image 2 more times, but not right now. I have said the word racism so many times, and I know that we have a general understanding, but I'm going to share with you my definition of racism. When I say the word racism, I'm clear that I'm talking about a system. So I'm not talking about an individual character flaw. I'm not talking about a personal moral failing. I'm not talking about a psychiatric illness, although it does present in all of those ways. But in its essence, racism is a system of power. And a system of doing what? A system of doing 2 things. A system of structuring opportunity and assigning value. And on what basis is the opportunity structured? And on what basis is the value assigned? It's based on so-called race, which is the social interpretation of how one looks in a race-conscious society. And in many different race-conscious societies around the world, you have different racial climates with different names and categories and sorting rules and stuff, and maybe even different benefits, right? But what that thing called race is the social classification of people in a race-conscious society. It's the street race. It's here. When I first got here in the UK in July of 2022, I was going to take a little course at the Academy or something, one of those, and it had a, you had a drop-down list, right, of ethnicities, race, ethnicity. And as I looked at that list and on into that list, I was very pleased to see that my efforts to try to understand the racial hierarchy in the UK have been answered to me in the order of the list. I don't know if you've noticed that, but it's not by alphabet. So it's not alphabetical. It's not by the number of people in the different groups. And if you, as you go down, because even within the so-called white, so you have white, English, white, Irish, I don't know where the Scottish, and I don't know. I'm just, you're the white traveler. And then so you get through all the whites, and then, it's really something. But then I came to learn that all those categories that the police use a different system. So if you call in and you just witnessed a crime or something, they ask you 6 categories. That is the race that's operating here. I don't know if it's black, white, Asian, I don't know what the 6 categories are. Look at it. But that is the thing. That is the socially assigned race that we started measuring at the CDC on our racism and health, the reactions to race module that we developed for the CDC. Anyway, I just digress on this too. What we call race is the social classification of people in our race-conscious society that we in the US, and here there are different categories. I haven't completely learned everything, but that we see somebody and without asking, excuse me, how do you self-identify? Or excuse me, where were you born? Where were your parents born? Or excuse me, a genetic hypothesis. May I have a little bit of your blood, right? We assign people these races, and that is the substrate on which racism operates day to day and has operated in both of our countries for centuries. What is the impact of this system of structuring opportunity and assigning value? Well, when people do recognize that racism exists, then they understand that it unfairly disadvantages some individuals and communities. But it shouldn't take any of us long to recognize that every unfair disadvantage has its reciprocal unfair advantage, so that racism is also unfairly advantaging other individuals and communities. That's the whole issue of unearned white privilege that we hardly ever talk about in our country, or here that I heard of in the year that I was here. And it's because it makes some people in the US at least uncomfortable, especially people who are living as white. And I'll talk a little bit more about that. I would just say this, that I used to apologize, or almost apologize, if I'm talking to a big group of people and I see people start squirming when I talk about how racism unfairly advantages some individuals and communities. And I would say, oh, I'm not trying to make anybody uncomfortable. If I make you feel uncomfortable, I want you to shake it off. Stay with me. I'll tell you more stories. Right? I don't do that anymore. I say, if you feel uncomfortable recognizing the reality of unearned white privilege, I want you to lean into that discomfort by reading more, by going across town and staying a while, having talked to strangers, whatever. Because I have come to recognize that for all of us, the edge of our comfort is actually a growing edge. But there's a third impact of racism that many of us miss, and that is whether it's unfairly disadvantaging or advantaging individuals and communities, racism is sapping the strength of our whole societies through the waste of human resources. When we don't vigorously invest in the full, excellent public education of all of our kids, right? If we, in the US, there's so much disproportionate incarceration of Black and brown men in our prison system. Here you have the differential section, section 8, mental health, whatever, siphoning off of Black men in the system. So that is not just a problem for those people and their families, it's a problem for the whole society. We are losing access to so much genius and power and leadership and generosity and all of that. And we don't recognize it. In the US, I'm going to say one more thing, and I may run out of time to tell the third story, but at CDC, when I presented it, so long story short, people got perturbed about at the last place I was in CDC, 14 and a half years. So in the last 2 years, when I had moved to a different part, we're like, you can't talk about unfairly advantages. Anybody, that makes white people uncomfortable. I was told that. But I was like, no, this is, the truth. And so the compromise was, well, if I didn't describe any as unfair, I could talk about advantage and disadvantages, as long as I didn't characterize it as unfair. Well, after I worked all that and escaped CDC and all that, then I recognized it wasn't just that one person, that there are many people in my country who might think that there are two states of being, right? But they might describe them as disadvantaged and normal. And the reason that they think they're two states of being, disadvantaged and normal, is that we are ahistorical and we act as if the present we're disconnected from the past, and as if the current distribution of advantage and disadvantage were just a happenstance. That's an important thing for us to recognize. Okay, that definition of racism that I just shared with you can be generalized to be a definition of any system of structured inequity. So, for example, what is sexism? That's a system of structuring opportunity and assigning value based on gender that unfairly disadvantages some, unfairly advantages others, saps the strength of the whole society. And I recognize there are many axes of inequity operating in our societies today, intersecting in communities, intersecting in individuals, and all of these are at least risk markers for how opportunity is structured and values assigned, even as many of them are also risk factors in the progression of disease. So this is, some of you came in since I said this, so I'll just say it again. When I present this in the context, and it used to always be like the last 10 minutes of my presentations, I would say, okay, so we've been talking about racism. There are many axes of inequity and their associated systems of structured inequity. People would say, well, Dr. Jones, why are you so focused on race as the axis axis of inequity and racism is a system of structured inequity. And my answer then, and it continues right here, racism is foundational in my nation's history and wealth. It is foundational in your nation's wealth and history. You know, you can, it is foundational, and yet many people are in staunch denial of its continued existence and profoundly negative impacts on the health and well-being of the whole nation. So when you have a situation like that, all of us need to at least be actively anti-racism. And I don't say anti-racist, because if you say anti-racist, people are like, oh, is she talking about me? No, I'm not talking about anybody as an individual. There are individuals implicated. But the first work we need to do is talk about the system. So I think we need to all be actively anti-racism, at least, even as we engage in struggles around all of these, or as many of these other aspects of inequity as we can manage. And to the extent that we're able to dismantle the mechanisms of racism, the other struggles will benefit us. So this is where I invite, this is where I invite a few comments, but have we run out of time already? Like, I don't have a watch or anything up here.
15 minutes.
15 minutes, okay, I'll be really fast, but let me take 2 questions or comments, unless. Yes, this one.
Thanks. I just want to try and clarify, make sure I understood properly what you were saying about police categorization of race versus how we describe ethnicity and self-described.
Yes,
What I think you're saying is it's then described by the person looking at it and their perception of it, not the internalization of it. And I don't know why this is suddenly an epiphany to me, but that is obviously, that is racism. And we focus so much on people self-declaring ethnicity, and it's almost irrelevant.
Yes.
Because what's relevant is how you're treated.
that's right,
And that's based on someone else's perception.
that's right.
And it does make me think there's a fundamental flaw actually in how we collect that and the efforts we go to collect it. And we need to maybe rethink that in a different way.
Yes, we can collect all of it because there is ethnicity, and there are people who have parents and grandparents and all behind them, and they have language and history and stories and all kinds of stuff like that. But race and the race-associated differences that we see in health outcomes is because of how people are treated in their experience and their opportunity structures and how they are valued and all of that. So I would be so bold as to say that racism is the root cause of race-associated differences in health outcome. I don't even call it racial or racial ethnic differences. I say race-associated. You hear the distinction there. And racism is the root of that. When we document race-associated differences, we need to ask why, and we need to ask why. So the whole reason that I, as a family physician, epidemiologist, molecular biology undergrad, you know, all of that, like no anthropology, sociology, political science, none of that in my history. The reason that I am working on race and racism now is I tried to figure out the answer to 2 things. Why do physicians in the US, why are we trained to present the patient by age, race, sex? This 18-year-old Black female presents with, you know, abdominal pain versus the 18-year-old white female. What are we supposed to get from that? Who are we supposed to see? What is the differential diagnosis and how does it differ, right? And so then I would challenge folks, and you know, when I was in my training, and then people give you all kinds of answers like, well, it makes it easier to identify the person in A&E, right? But really it boiled down to that's the data that we would talk. So then going back and finishing my PhD in epidemiology, then I was, you know, I had done family medicine residency, came back to finish. I was a teaching assistant. My students from the European continent and the African continent were like, why are all these tables Black, white, other? And that's how long ago I did this. So he's Black, white, other, you know. And why is that? You know, and I recognized that we were treating race as the explanation. So then I said, well, what does this variable race really measure? And if you ask people on the street here, or you ask epidemiologists, they would say it measures some combination of social class, culture, and genes. So then I don't have a lot of time, but I critique race as a measure of social class. In the United States, yes, Black people are more or overrepresented in poverty. White people are overrepresented in wealth, but not all Black people are poor. You know, it used to be the majority of poor people. Now it's still the plurality of poor people in the U.S. are white. So it's not a one-to-one correspondence. And the fact that there's any correspondence is because of structural racism, which hopefully I'll tell you the story really fast in a minute, which you'll understand. So then you say, Well, what about race as a proxy for culture? Well, there's not one white culture, just like there's not one black culture, or Asian culture, or Hispanic culture. And people, who are black in the US could have been raised in the rural South, urban North, just come from Sudan, just come from Nigeria, just come from Jamaica, could have even just come from Australia, not very recent, African roots, but be called black in the US and have very different health practices and the like. So there's that. So it's a rougher proxy for culture. What about race as a proxy for genes? We have mapped the human genome. There is no basis in the human genome for racial subspeciation. So then Dr. Jones, if it's a rough proxy for social class, rougher for culture, meaningless for genes, why do we see race so tightly associated with health outcomes across diseases, across genders, across age groups, across time? So you to say, what does it really measure? And it measures the social classification of people in our race-conscious society. If I get taken into A&E unconscious and somebody marks off my race, that becomes part of a health statistic, right? And it's the same race that they notice that a police officer notices, or a taxi driver, or that our judge in a courtroom, or a teacher in a classroom, and it is that race that has profound impacts on my health and opportunities in life. So yes, your aha is exactly the aha that I intended. So thank you. Anybody else with a quick? Yes.
I'll make it quick. Thank you very much. I like how you're presenting racism as a system and how it really requires a system-wide approach. I wondered if you could speak to how we might be able to encourage people to see it as that from both sides. So often I find myself in spaces where I, amongst other people who aren't white, are discussing tackling racism. But not often do I find myself in spaces where it is a kind of a multi-ethnic approach. So it does sometimes feel as though it's our problem and we need to sort it ourselves,
Right.
as to it being a social issue that actually affects everybody and would be for the better for everybody.
So the story that I haven't crystallized is the story that tells exactly that message, that last point, that racism saps the strength of the whole society. I have different ways of getting to it. I said there are 4 key messages when we're name racism. Racism exists. Racism is a system. Racism saps the strength of the whole society, and we can act. Dismantle racism. I do have a quick little story that can get to the system part if you guys want, but I have to say it means that we won't be able to do my gardener's tale, but you can find my gardener's tale, and you must. That was my first allegory, published in 2000, so 24 years ago. Very influential, and don't just like everybody has taken my stuff. For those of you who were here earlier, first time I'm putting a copyright thing on my presentations. So write this down now. So if you Google Camara Jones, Gardener's Tale, CDC 2002, that is, so 2002. Oh, the production value is great. 2002, it's not, but the words and all of that, perfect. I also have, in 2014, I did a TED Talk, a TEDx Emory. So if you Google Camara Jones TED Talk, then you will get in 18 minutes 4 of my allegories. So a quick version of the Gardener's Tale is one, a quick version of the Restaurant Saga that you heard, and then 2 others that you haven't heard and won't hear today. So those are 2 resources. If you want to read the Gardener's Tale, it's only 4 pages, so 2 pages front and back, that you can give to your friends, give it to your partners, right? It's like clear. That's American Journal of Public Health 2000. Okay, so now I'm going to answer your question about the system. Imagine, do I need to stop like right now? I think I'm going to sound. So this is a story that I call cement dust in our lungs. Okay. So imagine that there's a cement factory spewing cement dust, and the cement dust fills the air, and everyone who's anywhere near that cement factory gets cement dust in their lungs. Right? And this cement dust in our lungs is problematic for all of us, even though it might affect different ones of us differently. Cement dust in my lungs might make me think that I'm less than, so that kind of internalized racism. Oh, so when I say cement dust, think cement dust, but also think racism. So that might be internalized racism, whereas the cement dust in somebody else's lungs might make him feel that he can, with equanimity, crush the life out of another human being with his knee for 9 minutes and 29 seconds. But however the cement dust is affecting us, it's bad for all of us. And so the question is, what are we going to do? And it's even bad for people who don't recognize that they have cement dust in their lungs. So what are we going to do about the cement dust in our lungs? Well, we could start at the individual level, right? And so maybe, so I'm going to give you two individual interventions. So maybe we have some kind of screening machine, right? And it screens people for how much cement dust you have in your lungs, like an X-ray. And then if there's too much cement dust in your lungs, then an alarm goes off. So I think this is not a good idea. Although some people, there's the implicit association test. I mean, it's a good idea. People think they don't have any cement dust in their lungs. I mean, it can help. But it's bad because how much is too much dust? What are we going to do with those people? We can't vote them off the planet, right? And also it makes people not even want to talk about cement dust because they feel like if we're going to talk about cement dust, you're going to be staring deeply into their soul. How much cement dust do you have? Like, how racist are you, right? So that's the problem with that approach. But what if we have people who say, I know I have cement dust in my lungs and I want it out? Well, we could set up cleansing spots, right? And people could volunteer or be encouraged to go into the cleansing spa for a few days and weeks, and they could read more, read history, talk to strangers, whatever, and they could come back out and all the dust has been taken out of their lungs, good as new. But if they come into that same cloud, then the dust is going to quickly reaccumulate in their lungs. So it's not a very permanent solution unless they live their whole lives in the cleansing spot. But I just said an important thing. They come back out into that cloud of dust. But what if we don't focus on the individual? What if we instead focus on the cloud? Acknowledge the cloud, okay? So what does that strategy look like? Well, I know I'm in a cloud of cement dust, white supremacist culture, whatever you want to say. And I don't want it, that I need to put on a gas mask, right? Start my individual anti-racism journey, right? Recognizing that the gas mask is not going to extract all the cement dust that's already in my lungs, but at least it will keep new dust from coming in there, which means I need to be 24/7 about this. I can't be a little sometime here and there. And I'm also encouraged when I see myself reflected in a glass or a mirror that my mask is still on, it's intact. And now you guys see me and you say, well, Dr. Jones, why are you wearing a gas mask? And I say, now it gives me the opportunity to name the cloud, right? So, oh, don't you see all the cement dust in the air? Do you want to keep breathing that in? And so more and more put on their gas masks. They start their individual anti-racism journey. So maybe that's the answer then. Maybe in the US, we just need 330,000 gas masks, baby gas masks, old people gas masks here. How many do you need? 60,000? I don't know how many you need. Yeah. Maybe that's the answer. Well, it's part of the answer, but it's not really going to do things for people who, first of all, don't want that. And it's part of the answer, but what we really need to do is dismantle the factory. Now, most people can't even see the factory because it has thrown up so much cement dust, they don't even know there's a factory. But those of us with our gas mask, and we have clear things that clear our eyes too, we need to start organizing and get closer to the factory, and then we need to ask, how is this factory operating here? Which is like the question I shared with you, how is racism operating here? Looking at structures, policies, practices, norms, and values. And then we need to organize and strategize to act to dismantle the factory and set up a system in which all people can know and develop to their full potentials. So this is that these different strategies at the individual, at the kind of cultural or cloud level, and at the system level are all important, but we will not really set things until we recognize there's a system and dismantle the system. Did that help? It's not that I usually have slides and stuff there, but did you guys get it?
Yeah, right.
Okay, so we can hold that. Okay, so here's the quick thing about the levels of racism, and really please tonight, or at least by the weekend, look at it's an 18-minute video from 2002 CBC. It's an interview, and it's great. 2002. The reason I had to do that video, not because people wanted, because my people at CDC didn't want me to travel. So anyway, so we sent a video instead. Oh, no, it's hard. But anyway, so the 3 levels of racism that I talk about are institutionalized or structural, personally mediated, and internalized. Here I define each of these. And the important thing to know is that, well, I won't have time. So look at this, but, well, structural racism is differential access to the goods, services, and opportunities of society by race. It shows up in so many different ways. It shows up in differential access to resources and to power. And it explains why race and social class are even related to one another in the US and a bit here. Personally mediated racism, also differential by race, differential assumptions about the abilities, motives, and intents of others by race, and then differential actions based on those assumptions. This is what most people think of when they hear the word racism. It's the prejudice, the different idea, the discrimination, the different action, lots of examples. And like structural racism, which I didn't say, which can be through acts of doing as well as acts of not doing, acts of commission as well as acts of omission. That really characterizes both structural and personally mediated racism. In fact, for structural racism, it very often shows up as lack of action in the face of need. That's a hallmark. When you see lack of action in the face of need today, then you're seeing evidence of structural racism, right? But like that, personally mediated also, but also personally mediated racism doesn't have to be intentional, right? You don't have to have intended to do something racist to have had a racist impact. The third level of racism is also differential by race. Internalized racism for members of structurally disadvantaged races is acceptance of negative messages about our own abilities and intrinsic worth. For members of structurally advantaged races, it's an internalized sense of entitlement, which actually then leads to racism denial, because if you feel entitled to everything you have, then how could there be an unfair system going on? Normal. And then here is how it shows up for members of structurally disadvantaged races. For members of structurally advantaged races, in the US, we're now using the terminology diseases of despair. For white folks, you know, who have higher suicide rates or more of the second opioid epidemic, diseases of despair, which is like you feel entitled to something and then you're not getting it. And actually it's contributing to our political horror that is unfolding in our country. And for people of structurally disadvantaged races, it's about accepting limitations to our own full humanity. So how much time can you guys wait? How much time? If I told this in 10 minutes and wrapped up. No. Oh, it's closing. So anyway, you look at that, who's just, you'll find me all over online. Who is the gardener? How is racism operating here? I must just say this. That question is important. That moves us to action. That's the landscaping. We need to look at structures, policies, practices, norms, and values. And I just gave you a headache until we recognized that these are actually the elements of decision-making. Structures are the who, what, when, and where of decision-making, especially who's at the table, who's not. Policies, the written how. Practices and norms, both the unwritten how. Practices now, norms deeply embedded. Values, the why, and I'm just going to quickly go through that. There are differences between those who value comfort. Many people value comfort. And those who value social justice, many people value social justice. In our current schema, valuing comfort and valuing social justice are at polar opposite ends of a value system. Those who value comfort are very much like those born inside the restaurant, sitting at the table of opportunity, eating. They are benefited by the status quo, which is why they value that status and comfortable in the status quo. They don't wonder why nobody else is coming in. They don't want to examine the sign or care to know what outsiders are saying. They don't believe an outsider could add to their conversation. They don't even wonder how the food they're eating gets there. And they certainly don't want to budge from their seats at the table. They feel entitled to those seats. They don't even recognize, you know, that as a privilege. Those who value social justice value it because they know two things. They know there's a two-sided sign going on, and they know that the operation of that sign saps the strength of the whole society. Not saying that the circumstances of our birth consign us to our values, but and there are people who move in both directions. We don't need to talk about that. We could for a long time. This is what I wanted to tell you guys about as public health people. Sorry, bring me back. And what can we do today? What can we do today? We need to actively look for evidence of two-sided signs. Don't, just because it says open to you, don't think, oh yeah, it's open for everybody. That means look at differential opportunities as well as differential outcomes by race, by gender, by location, rural, urban, by all of that. We need to burst through our bubbles of experience to experience our common humanity on the other side of town. We need to be interested in the stories of others, believe the stories of others, join in the stories of others. See the absence of it's a very important skill. Who's not at the table, what's not on the agenda. reveal lack of action, inaction in the face of need. That's how structural racism often shows up. But the power is not all on the side of those inside the restaurant. Those of us on the outside need to know our power, recognize that action is power, and especially that collective action is power, because it informs us, inspires us, propels us, protects us, and so much more. And I'm sorry I couldn't get into detail on that.